Move on to Dr. Cooper, Dr. Tony Cooper. He's from University of British Columbia. He's the head of pediatric orthopedics there, and he's done a lot of work, groundbreaking work on international collaboration and patient-reported outcome measures on a global scale. So, Tony, you can take it away and share screen, please. You're muted, Tony.
Thank you. So thank you so much for inviting me today. This is a great conference, and thanks for a fantastic presentation. Before that, that was a great comprehensive summary of limb differences. I just want to make sure everyone can see my screen. So today I'm going to talk to you about a couple of things. First of all is the International Limb Difference Network, and then also with that, the LimbQ Kids, which is a validated patient-reported outcome measure that we are developing here at the University of British Columbia. I just want to acknowledge that our program is situated on the ancestral and unceded territory of the Coast Salish peoples, which are the Musqueam, Squamish, and Tsleil-Waututh nations. These are my disclosures. So the International Limb Difference Network is a network designed to improve the quality of life of children with limb differences. And we use prospectively collected data from multi-center studies, multi-center real-world data to inform knowledge sharing, scientific collaboration, teaching, training, access to care, and advocacy. And we have multiple condition-specific sub-registries. Currently in production are ones for Blount's disease, fibula hemimelia, musculoskeletal infection, and osteogenesis imperfecta. And we have several more that have been already produced and running, which is a CPT registry and a Morquio B registry. The ones in white that you see here are ones that we are about to start. So the network structure consists of some network mentors and at the core of the scientific advisory committees. We have research methodology panels who are there to look at the research and allow people to access the data that they contribute to the networks, as well as special interest groups. Each sub-registry is led by 2 scientific advisors, and one scientific advisor is from a high-income country, and one is from a lower middle-income country. And the reason for that is we want to be truly globally applicable. We want to be able to have the full spectrum of disease and the full spectrum of presentation and treatment. Each of these scientific advisory committees is supported by a research assistant and a data management team in the back end. It's all driven by REDCap and all web-based data entry. We develop the databases, finalize the data fields, and create a structure and organization, which is led by the SAC, and then these are rolled out with testing and editing. We currently have the ethics approved, and then once the registries are developed, the centers are onboarded, and we're rolling out each registry as we move along. We found that it's much more useful to have individual disease-specific registries, as this can streamline data entry rather than trying to have one large database which encompasses all of the different disease spectrum that we've seen before. Okay. So the vision of the International Limb Difference Network is that no child suffers from a limb difference, and our mission is to improve the quality of life of children with these limb differences. It's based on 4 core principles, which are equal access to care, research, and education. The principle that we think globally but act locally. We want to build sustainable capacity and do what matters most to children. There are 4 themes within this. One is to produce new knowledge. The second is to improve clinical care. Third is to build communities. And fourth is education. Within the producing new knowledge, the whole backbone of this is our registry development. We use these prospective observational studies as a base for longitudinal study of children until at least skeletal maturity. And also within this is a framework from which we can then develop a priori research questions. Patients can then be streamlined into these prospective studies and then back into the registry. One of the key things that we've identified with this, and we'll talk about a little bit as I move forwards, is the LimbQ Kids, which is a validated patient-reported outcome measure to look at the impact that treatment has and these diseases have on children's quality of life. In the theme of improving clinical care, we have a policy of continuous quality improvement. We're just wrapping up our multi-center pin site infection study, which has been a large and long-term study looking at prospectively looking at pin site infections in external fixation. We're just about to start the pediatric orthopedic implant safety and efficacy study, which is going to look at adverse events associated with orthopedic implants. We also have a strong background in surgical innovation. We have at the BC Children's Hospital, we have a digital lab, which is a 3D printer and also digital development. And we are developing AI and convoluted neural networks to analyze the radiographs that we are importing into these databases. And we use this for data-driven improvement in care to inform policy at a local, provincial, and a global level in order to deliver holistic and multidisciplinary care. In terms of building communities, there are two different arms to this. There's the patient arm and there's a professional arm. Within the patient arm, we have the Walk Tall program, which consists both of local events and building patient resources, and the ILDN, which is the professional arm aimed at healthcare professionals who treat children with limb differences around the world. In terms of education, we created patient and family resources, which are accessible on our Walk Tall website. And for healthcare professional training, we run annually a course, Canadian Pediatric Orthopedic Trauma course, and we're very proud of our fellowship training here in BC Children's. We have over 40 fellows from around the world, from every continent, who have graduated through our fellowship program. In recent years, we've had a targeted effort to improve the capacity for pediatric orthopedic care within East Africa. Starting in 2020, Dr. Jal Baraza, who's now back at the Aga Khan Hospital in Nairobi, was the first fellowship-trained pediatric orthopedic surgeon in Kenya. Following that, Dr. Judith Nasazai joined us from Uganda. She's now back at Korsu Hospital, and she's the first female orthopedic surgeon and fellowship-trained pediatric orthopedic surgeon in Uganda. We've currently partnered with the University of Rwanda, and we are very happy to have Emmanuel with us, who is from the Kigali Military Hospital. He is spending 18 months with us, and then we'll be returning there to develop a pediatric orthopedic program. Following that, we have a surgeon coming from Ethiopia to spend a year with us as well. In terms of development of the LIMQ kids, a little bit of background is that I think we're all familiar with this study from Dr. McCarthy, whose main outcome was that children who have early amputation for the treatment of fibular hemimelia are more active, have less pain, and are more satisfied with the results of the treatment than those patients who have limb lengthening, even if they've achieved equal leg length. And so that did not really sit with me, and it brought up a few questions. So really the question is, if that's the case, children who undergo limb reconstruction surgery, should they really be spending all their childhood here with me at the Children's Hospital, or should we be not seeing them at all, have an amputation, and then spending their time enjoying their childhood with their friends? But the reality is that amputation, as we all know, in children is not a fire and forget procedure. And multiple other factors that go into this. Small surgeries are required as they develop. There are multiple issues which we need to consider. And perhaps it's that these studies aren't really capturing some of the true impacts that having an amputation has. For example, do these studies capture what it feels like to have to get up in the middle of the night to put your leg on to go to the toilet, or what it's like to have sand in your prosthesis when you go to the beach? So we started back in 2017, and we performed a systematic review looking at the number of studies that are out there and what patient-reported outcome measures were actually in use. And what we found is there wasn't a validated patient-reported health-related quality of life for children with limb differences, and most studies use surrogates, so either adult measures, generic measures, or ones which were very system-based. So we decided we would develop our own. So having no expertise in this, we engaged the Q portfolio team, which is led by Anne Klass and Andrew Pusick. Anne is a pediatrician at McMaster, and Andrea is a plastic surgeon over in Boston. And they have a very extensive portfolio, including, as we started off with the breast and the cleft lip, and then multiple patient-reported outcome measures. So we started the journey to develop the LIMQ kids. There's several steps in this. The first one is item generation, which is where you identify through both qualitative and quantitative measures a preliminary conceptual framework and items and scales, and these are then refined. So you end up with a huge number of potential items that you could be asking. The next step is to reduce those items, and then finally is a psychometric evaluation of the responsiveness of these tests. And I'll talk a little bit more about these steps as we go forwards. So from our original systematic review, we identified three main areas: physical health, psychological health, and social health. And you can see some of the fields within that here. And then as we moved along, we then performed an international qualitative study, which was effectively interviewing people with limb differences from around the world. We had centres both in Vancouver and Montreal for French and English-speaking Canada, one in the USA, one in Ethiopia, and one in India. And through this, we developed a conceptual framework of health-related quality of life and to identify what was important to children around the world with lower limb differences. From this, we then developed the framework expanded to include appearance, so particularly looking at things like scars, the appearance of people's legs, the use of clothes and other devices, their physical health, both in terms of function and symptoms, psychological health, which included body image, distress, confidence, and self-esteem, the impact it has on school, and also social health. We also identified some mediating factors such as emotional support and coping structures. From this, we refined this more. So the appearance scale didn't really change, but one of the big things that changed was our physical function scale. And within that, we subdivided this into leg symptoms, hip symptoms, knee symptoms, and then foot and ankle symptoms. We also refined our psychological health into a psychological function, and particularly a leg-related distress scale. We looked at school function and social function. And from this, we were qualitative interviews and we then consulted with some experts, both in the patient-reported outcome measures and also experts in the world of limb differences. And using some guidelines from literature, we then had to think about the item lengths. We wanted to make sure that the outcome measure wasn't too burdensome, that the wording was clear and concise, that the reading level was at the reading level of someone in age 8. We had to look at the response options because children are very prone to, if there's a neutral option, they'll choose a neutral option. And then we also had to think about the recall period. What's the period of time? Because obviously limb differences last a lifetime and the impact can be different at different times. So the recall period that was important for this. So here's a few of the quotes that we had. So from this and I'm just going to illustrate how we use this to generate some scales. So one example is this leg would be bigger than this one, and this one was always skinnier. So then skinny. So they asked, how much do you like the length of your leg? The size of your leg. Is it not too skinny? I have to wear long dresses to cover my legs, or my leg would look crooked. So how well do your legs match each other or look the same? How straight your legs look when they're not crooked or lopsided. How your legs look in a shorts or skirt. I can find clothes, but you can clearly see my leg problems when I wear shorts, and I always feel ashamed wearing shorts, so I prefer not wearing them. How do your legs look when you wear pants or jeans? So once we've developed this scale, we then had to look at the content validity, and that's the empiric evidence that demonstrates that the items and scales of an instrument are appropriate and comprehensive relative to its intended measurement concept, population, and use. So effectively looking at comprehension, comprehensiveness, and relevance. And in order to do this, we conducted 40 qualitative debriefing interviews across 6 different countries and 11 different sites in order to establish our content validity of the PRO. We're currently at a stage now where we are in our international field testing. And so we have 15 countries and 25 different sites. We're also performing translation and cross-cultural adaptation into multiple different languages. Here's a map of the centres that we are working with for this. And here is our current status. So we are approaching 450 recruits within us across 15 countries and 25 sites. So we're hopeful that by the end of this year, we're hopeful to have a measure which is kind of validated and is ready to be released. And hopefully this will be something that we can use as part of our limb difference network as one of the outcome measures for this. So we use the International Society for Pharmacoeconomics and Outcomes Research best practice guidelines for our translation cross-cultural adaptation. Here are the different languages that we're developing in. We've completed our Danish and our German ones. We're approaching completion of Hindi, Arabic, Hebrew, Spanish, Swahili, and Portuguese, so that we can really have a global kind of relevance to this PRO. And so the significance of this, that we've validated and developed this through the engagement of children with lower limb differences. It's going to be internationally applicable and available in multiple languages. And we also want to use this to be both measure the impact of lower limb differences on the health-related quality of life of children, and also to help assess the impact of treatment options. Hopefully this will become a common metric for outcome assessment for children with lower limb differences internationally. So thank you very much for the opportunity to present today. These are some of the people that have supported our program. If you're interested in being involved either in the use of the PRO or as part of the International Limb Difference Network, please email me and I'd be happy to take any questions.